Okay, so now I'm going to introduce myself, which saves a few seconds of time, which is great. I'm giving the next talk. Let's see, yeah, great. So I'm going to talk about reflux and IPF. I think most of the data is in IPF. Some of it may extend to pulmonary fibrosis more generally, but I want to just tell a story here of kind of the narrative of science and where we are in this question right now, and maybe challenge the group to think about what the next steps are, both from a research perspective and also from a clinical perspective, because we don't have the answer yet. And these are tough things to figure out how to kind of solution. So this is my cover slide. This is, I'm from UCSF. You can hopefully see our nice campus there, which is a 360 view. It doesn't really, it looks kind of warped, but it's a beautiful place to practice. Next slide, please. Or do I control it? Yeah, I control it. Great, I have no disclosures. I want to start with a case. This is a very typical case of IPF. There's not meant to be any complication here. 65-year-old with cough as a primary manifestation. Some typical comorbidities that we often see in this age group and disease. A history of some heartburn. Some other things that throw in questions about the diagnosis, like exposure to down. And all of this led to a CT scan that was non-diagnostic and a lung biopsy, which showed a UIP pattern, which the bottom is just a small section from. So this is a common narrative of a patient getting diagnosed with IPF. This patient, however, had additional testing, which included esophageal manometry and pH testing. And some of you in the room may have had this done. It tests for function of the esophagus and how much gastroesophageal reflux, or movement of fluid and other products from the stomach back up into the esophagus, how much of that occurs. And in this patient, we saw there was normal motility, so normal function of the esophagus, but abnormal reflux. There was an elevated amount of time with a low pH. The gastric contents are acidic, which have a low pH. So the more time you measure a low pH in the esophagus, that means that acid is coming up into the esophagus. And a Demeester score, which is a combination of a variety of measures like time and pH, was elevated. A normal level is around 15, and in this patient it was 39. So this means the patient has significant amounts of gastroesophageal reflux. And so this patient was sent for laparoscopic anti-reflux surgery, which I'll explain a little bit later, but is a common procedure done in cases of, some cases of gastroesophageal reflux. And this is the natural history of this patient. This is a real patient of mine. From the time of fundoplication in 2007 or so, up until at least the time of starting antifibrotic therapies when they became available just before. I think this patient actually was in a study, so got it a little before approval. And you can see that the main measure we follow, as probably most of you know clinically, is forced vital capacity, or FVC. That's the blue line, and it's stable. So the question is, what's going on? And I want to pay tribute to two people. One of them is Ganesh. You all hopefully had a chance to hear from Ganesh during this conference. I know he was here this morning. I think it's really important we listen to people who are, contrarian is too negative a word, maybe are pushing the boundaries, coming up with ideas which seem a little out there or hard to, kind of hard to believe, don't resonate with kind of the, maybe the current paradigm of how we're thinking about things. Those people are really important to groups and can sometimes come up with directions that are important to follow. I think Ganesh is one of those people, and he, for years, talked about this relationship, at least my experience in the ILD community, which dates from about 2004, 2005. Ganesh was the voice bringing this up, and there weren't many other voices for a while. But he recognized this relationship in patients. He published on it in the late 90s, showing that IPF patients specifically had elevated levels of reflux compared to other ILD patients, so not even a non-ILD population, but to other ILD patients, suggesting that maybe there was something about reflux and IPF that was important. Those types of clinical observations, I think, are often the first clue as to where we should look more carefully at mechanism, and they can help drive discovery. So clinical observation and clinical studies, epidemiology, descriptive studies are very important in helping us focus our research. So I think Ganesh deserves a lot of credit for that. The other person I want to credit is Joyce. Joyce Lee, I think you also have had a chance to hear from here. Joyce joined my lab as a fellow in 2009, so 10 years ago. And she had an interest in this association. And my point here is to say two things. You need someone kind of smart with energy and time to look into new areas. And we need to encourage that. We need to encourage people to take some risk. This is an area that didn't have a lot of data behind it and evidence behind it, but it was a good idea, and it needed some important clinical research done. And Joyce did that. And I think that's something we should all kind of remember and encourage. And it's one of the places that the foundation is playing an important role in supporting fellows. So Ganesh and Joyce have a lot to do with this story. This is a picture from a paper that Joyce published back in the 2010, which just shows you the mechanism, the mechanism here it's hypothesized, which is that, I don't think I have a pointer, but hopefully you can follow the arrows from the bottom of the screen, that the contents from the stomach, which is at the very bottom, come up into the esophagus, which is the long vertical tube. And if they come up far enough, you see the arrow comes around, they can get down into the trachea and then down into the lungs. And the concept is that in the lung, which you see then expanded in these two images, you can aspirate or have that fluid get into the lungs and deep into the lungs and actually affect stress or injury even in the lung epithelial cells. And that can come from a variety of sources, acid or the non-acid components like food particles, bile salts, pepsin, other things that are in the stomach. And that over time, that can cause repeated injury and repair and could be a driver of kind of progressive scar formation, either in someone who already has a lung disease that makes their lung susceptible, or potentially as a causative condition. So then, over the next few years, Joyce published a couple of papers I want to point out to you that laid the groundwork for the study that's the main presentation today. The first one was looking at survival in patients who had a variety of different metrics of reflux, either reflux medication use, reflux diagnosis. This survival curve I'm showing you here is for medication use, looking at those who were on medication for reflux, which is the dotted line, or those who weren't. And these survival curves, many of you are probably familiar with. Basically, the x-axis is time, and the y-axis is risk. In this case, as the slope goes down, more of these patients have died. And you see that the difference between those taking the medication and those not taking the medication suggests that the medication is associated with prolonged survival and may have a causative role. This was statistically significant, as you see by the last bullet there. So this was interesting and supportive data for there being potentially a role or relationship between reflux and disease progression. A second study was looking at the risk of exacerbation, which you've heard about as one of the key clinical complications in IPF. One of the things I mentioned that's in the stomach is an enzyme called pepsin, and this study basically looked in the lungs and said, is there more pepsin in the lungs of patients who've had an exacerbation than stable patients, hypothesizing that one of the reasons for exacerbation might be an aspiration event or reflux. And what this is showing is that in a subgroup of patients, about 30%, as you can see on the far right, each dot is a patient. And the higher the dot, the more pepsin in their lungs. You can see there's a population of patients that are elevated compared to the control group, the stable disease group. So suggesting that in some patients with exacerbation, there may also be a role for aspiration from reflux. I'll just point out one other interesting finding here is that about half of stable or unexacerbated IPF patients also had elevated pepsin levels. So it could be that there's some kind of chronic lower level exposure and aspiration that also could be important. So in other words, it may not just be causing exacerbation. Those may be very high levels, but you also might have lower levels. And then lastly, I show you this combination of data of combination of 3 studies that were trials done for other reasons through what's called the IPF net, and combined the patient data and looked at the progression by forced vital capacity of patients who were either taking anti-acid therapy or not. And the red group here is those who weren't taking anti-acid therapy, and the blue group is those who were. And again, you see the slope of change over time in lung function is less than the untreated group. Again, suggesting that there may be a relationship between treatment of reflux and rate of progression. Okay, so based on these data, which aren't perfect and have a lot of holes you can shoot in them, that this was enough to suggest and warrant a clinical trial. And so in 2012, this is the letter that Ganesh and I sent in to the NIH to support this trial. And importantly, this was a collaboration with a number of people in the room. I've listed the centers there in blue. And I also just want to recognize the NIH. This is the type of study that the NIH is, I don't know if uniquely positioned to fund, but this is a challenging question to ask. There's no kind of financial return on this, to be blunt. That's not the only thing driving industry investment, but clearly there's a business model that this may not support. We need a way to ask these type of questions, and I think the NIH has really invested in doing that and made this possible. This was our target population. If we had more time, it'd be really interesting to talk with you about why we made these decisions and whether we could have been more inclusive. We tried to be fairly broad, diagnosis of IPF and an elevated Demister score. Remember, that's the measure of amount of aspiration, or reflux, sorry. And then exclusion criteria, which were mainly driven by safety concerns or a desire to make sure that there was enough preservation of function that we could see a change if this intervention caused a change. And the intervention we tested was anti-reflux surgery, with the hypothesis that it was more than acid that was perhaps important here. We wanted to actually stop the reflux, not just change the acidity of the reflux. The medication changes the acidity, but doesn't change the fact that you're actually refluxing. So we wanted to actually block the reflux and then test over a year's time the impact on, as you now know, fairly traditional endpoints, forced vital capacity and some clinical measures. This is the publication that came out in 2018. I want to recognize this was a decade after Joy started her studies. We've talked a lot about the time it takes to bring therapies to clinical practice. This is really unacceptable. And we pushed the normal mechanisms hard to get this done in 10 years. 10 years. I'm going to skip that slide in the interest of time and just show you the baseline characteristics of the two populations. It was pretty well matched, but in small randomized trials, you sometimes have differences, and it's important to point out there was a difference in gender, or sex, I should say. There were fewer female sex in the surgery arm. And there was a slight difference in baseline antifibrotic therapy. More patients in combined pirfenidone and nintedanib than in the non-surgery arm. We can talk about that in the questions if you like. We adjusted for that in our analysis. Other things look pretty well matched. Here's the primary analysis. There was no statistically significant difference in the rate of decline in forced vital capacity. So the take-home message from this and the publication was that we showed no difference. This is the figure showing the estimated slope of the two groups. You can see the no surgery group did have a greater slope, but we can't be confident that that's real. There was another types of analysis we did where it was more significant, but the primary approach was not. And just to point out one of the secondary endpoints that is, again, not statistically informative, but I think important, is that there were 4 deaths during this year in the non-surgery group. There was 1 in the surgery group. We should not draw any clear conclusions from this difference in numbers. There's way too much risk of just error driving this. But there was a difference, and maybe the main thing I take from this that I think is hypothesis generating or raises questions is that all of these patients had an acute exacerbation right before their death. And if you remember the study showing that there is some evidence of aspiration being a potential risk factor for exacerbation, and we know all of these patients had significant reflux and therefore aspiration, it makes me wonder and worry that this is a population particularly at risk for exacerbation, and their risk may be driven by their reflux. This is speculation. We cannot, I just raise it as a way in which I think these data can be useful to us in coming up with hypotheses to test. And that's where we are today. So I have a question for you about this case to close. I just show you again the post-fundoplication lung function. I want to see a show of hands. How many of you believe the anti-reflux surgery that this patient had helped to stabilize this patient's IPF over that 8 years that I'm showing you? From diagnosis to he did eventually decompensate. Okay, now everybody has to vote. And you can't put up 2 hands. I see your 2 hands. Okay, and how many of you feel like it? Probably not. Okay, so this is very unofficial, but I think you all can't see from here, but I would say this actually does reflect what I saw in the room. And I've asked this question in many groups, and it generally plays out about this way. About 60% feel like yes, and about 40% feel like no. So, it's maybe more likely than not, but certainly not certain. So what do we do with that? So my final slide is what do we do with that? And I'll actually put both of these sections up. So in terms of what do we do from a research perspective, I think we need to do more research. We need to answer this question more definitively. What does that look like? We need to think about that as a community. This is a big challenge. These are very difficult studies to do. It took us 5+ years. It was hard to enroll. It's a challenge. What does this look like? Can we think about novel ways of doing studies? You heard about pragmatic studies. Can we think about using the data we have from clinical practice to kind of mimic a clinical trial, try to control for other variables and see if we can get at answers that way? I think we need to be innovative, and we need to push to answer this question. In clinical practice, what does the treatment of reflux for IPF look like? This is a place where I think the principle of a patient and provider decision is really essential. It's essential always, but particularly here, the decision-making should be joint. I think what I try to do is share this information and have the patient help me decide how they feel about the balance of the potential benefits and risks. My general approach is to treat symptomatic reflux with oral therapy, to not routinely screen people for reflux, but if they have progressive disease, to suggest or consider pH study and manometry, with the idea that if they have abnormal reflux, we're at least together considering then having fundoplication surgery based on this. It's a very difficult position to be in, I think, as a community and as a patient when you have these limited data to make this decision. So I really hope we can push the first bullet forward so we can have an easier time with the second one. And I'll stop there, and it looks like I left myself about a minute for questions. So thank you. I'll take maybe 1 or 2 questions if there are some. Yes, there's a question here in the center. If we could get the microphone, maybe just, there's one coming behind you.
Hi. How do you approach hiatal hernia when you see that on the scan? We only talked about reflux, but if there was hiatal hernia, which is related to this, obviously, Any insight into that, please? I struggle with this at the bedside. Thank you.
Yeah, so hiatal hernia is a herniation or movement of some of the stomach up kind of through the diaphragm. You can see it on imaging. We think of it as a risk factor for reflux. I think in terms of surgical management, it can be, if it's relatively minor or sliding, it can generally be managed with similar surgical approaches. I think the challenge is in people who have substantial hiatal hernia, and I think that's really difficult. I don't have a good kind of algorithm for that. But I do think it's something worth, if you know someone has a hiatal hernia or you see one, it certainly makes me think more about this. I'm not sure I know how that changes the algorithm, but it's one of the clues I guess you would use to kind of consider further testing. Hope that helps. Maybe one more question?
Left, Hal. Over here on your left, your left. Yeah, there we go.
Hi, Dr. Collard. Thank you very much for that presentation. I wonder if there's been any post hoc analysis on the groups to see if maybe there was some subset that was selected for that you just happened to get like a high risk group that on one side that didn't get the surgery and then a low risk group that did it maybe through a genetic classifier or something like that.
That's a great question. It's hard in these small studies to know how to make a whole lot out of that, but we are working on that. I don't know if Paul Walters is here, and he's been leading that for the larger group, but we hope that there'll be maybe some clues that come out of looking at biomarkers or other kind of molecular signals that might help us at least come up with some hypotheses as to why that's different. But it's hard with such a small number. Yeah, it's a great question. Okay, thank you very much.